This conference will now be recorded.
Good afternoon, ladies and gentlemen. We'll be talking about the topic management of ventral hernias. What is changing? Ventral hernia management is still an evolving discipline with new perceptions and innovations evolving frequently. The changes are many, but it would not be possible to discuss all of them in the short time available. So I will be mentioning just a few of them. The problem, if you look at the problem, repair is easier said than done. It's basically a plastic reconstructive procedure. You have to remember there are so many variables attached to the repair, like size, the number of defects, like a Swiss cheese defect, the extent of interabdominal adhesions, required operative competence, so on and so forth. So no one size fits all policy has to be adopted in the repair of ventral hernia. The perception, number one, the goals of management. Initially, it was just prevention of visceral eventration by a repair, either with or without a mesh, a primary repair. Restoration of role continuity did the job in a tension-free manner. But the new perception has to do with the recognition of the concept of abdominal domain and re-establishing it. And the definition of abdominal domain is important. Why? Because that could form an endpoint for reporting the data by various studies. So the new understanding is basically incorporation of the remaining abdominal wall has to be done, and that also as a dynamic muscular support, and that would lead to an increasing the function of the abdominal wall. So we have to recognize the abdominal domain. The basic question is which one is better, the LVHR or the open repair is better. Now, up to now, only two advantages have been ascribed to LVHR. Number one, the lower rate of surgical site occurrences, especially surgical site infection, and the less amount of bleeding. Substantiated by a number of meta-analysis. The contentious issues still remain, and they are concerned with the recurrence rates and post-operative pain, and we still don't know which is better because at a 35 months follow-up in a prospective trial, we had similar results for both LVHR and the open repair. Now, the defect closure is another feature which is now being increasingly recognized, although I must say that IHS 2019 recommendation is a weak recommendation that it should be closed. But those who were closing it, the initial reluctance was there for most of the surgeons, but now more and more surgeons are doing it, like example, as a part of IPOM, as a IPOM Plus, where the initial defect is also closed. So the advantage which have been ascribed to the closure of the defect, the possibility of reduced seroma, the reduced recurrence rate, abdominal wall function is better. And then, of course, what is probably true is the abdominal wall contour is much better maintained and prevention of ballooning of the mesh into the defect. The closure techniques could be both intracorporeal suturing, or it could be with the help of barb suture, or it could be a lap-assisted interrupted transfacial suturing, which is probably easier and could be done by even the early or let's say the novice laparoscopic surgeon. He can also do a transfacial suturing. But the problem comes when the effect size quite wide, and in these cases you can neither do a intracorporeal suturing nor can you do a transfacial suturing. So what do we do in these cases? In these cases now what has come up is the lap component separation, where with the help of this you try to close it in the midline, but it is a cumbersome, time consuming, high rate of complications, and still we don't have specific prospective or comparative studies which can tell you that yes, this is very good. The mesh size is again very important, and we were taught that, or we still believe that 5 centimeter overlap of the mesh the normal tissue should be enough. But we all know that the larger the defect, the size has to increase because we still keep it as a 5 centimeter overlap, the recurrence rate keeps on increasing. So what has now been suggested is the mesh area defect area ratio should be at least 16:1. And the mesh radius or the mesh diameter should be more than 4 times the radius or the diameter of the defect. So that is a huge change, but it's still not being backed by the recommendation of sages who still say that is 5 centimeter overlap is quite enough. So what are the options available for the LVHR? The options, the new options, we talk about the new options. One is the IPOM Plus, where you're also trying to close the defect along with the mesh being used. The hybrid approach, usually seen in those or required in those cases where you try to deposit the container sac back into the abdomen, you're not able to do so. So you open up the hernia sac, and with the help of open pushing back into the abdomen, then you close the hernia sac and you carry on with the laparoscopic procedure. Or you can do a tap just like in inguinal hernia, I can do a TEP or E-TEP, especially for the infraumbilical hernias. And of course, the new innovation or the latest to join the bandwagon is the edge mobilization, what we now know as the component separation technique. And this helps why? Because it avoids vast skin flaps and allows closure of large abdominal wall defects. It helps in that. And insertion of a retromuscular standard sublim meshes is very much possible once you have done the total the total dissection in between the trans abdominis and the transalis fascia, and without damaging the vessels and intercostal nerves, of course. And then you can do a hybrid CST also, what's known as the Mildos procedure. We'll talk about that. And then, of course, the robotic is essential in all kinds of procedures. So similarly, out here, the robotic procedure is used. Now, if you look at the CST options available, there are two variables. Number one, it can be done either as an open or lap, and it can be done as an anterior or posterior. Now, anterior CST does not have too much to recommend it, where the epineus of the external oblique was slit, divided from the costal margin right up to the pubic bone, so that the underlying layers could be slit on to the midline, and the external oblique remained where it was. So the problem with this was that it used to damage a lot of nerves, and there was atrophy of the rectus abdominis, resulting in an increased recurrence rate. The problem with this procedure was then solved with the fact that the perforator sparing CST was done. So we have anterior CST with perforator sparing, which gives almost equal results as an open posterior CST with or without a mesh. But among all these CST which are being tried now, the most commonly done is the open CST with the TAR, the transabdominis release operation along with a mesh. That's the most commonly done, but now increasingly it's also being tried out laparoscopically. So you can do a laparoscopic similarly, a posterior CST with a TAR and a mesh. So these are the two procedures which are now being done increasingly. The anterior CST is not very commonly done. The TAR procedure is one of the major advances of abdominal wall surgery of the last decade. Remember that. So before you go and do a CST, you have to remember the anatomy, and the anatomy has to do with the fact that the nerves of the rectus abdominis, supplying the rectus abdominis and the abdominal wall muscles, they are lying in between the trans abdominis and the internal oblique. And from there, they are coming to the edge of the rectus abdominis. You can see it out here. This is the rectus sheath. So the sheath, edge of sheath, and they perforate into the sheath, and then they lie on the posterior rectus sheath for about 1 to 1.5 centimeters, and then give a ventral branch to the rectus abdominis, which is lying anterior to it or over it. So this part, 1 to 1.5 centimeter, very, very important, because in mobilization, if you damage this part, you're damaging these perforators, and these perforator damage will then lead to the atrophy of these of the rectus abdominis, and that would be a real problem, because then that would lead to increased recurrence rate. So this part of the anatomy has to be remembered. And if you look at this figure, it can be done as this is basically the mobilization or the TAR procedure, which is done as a bottom up, basically meaning you start from the arcuate line, go up, or it can be done as a classic top down, where you starting from the costal margin and going down towards the pelvis. So either a bottom up or a top down incision can be given, and what you can see out here is the nerves have been spared. See, the nerves have been spared. You don't touch this particular area for dissection. You don't touch this particular area. These are segmental nerves. So the incision line is lying medial to these segmental nerves. And here's the rectus muscle. So the nerves are easily entering the rectus muscle. There's no atrophy of the rectus muscle. The nerves and both the vessels are not being damaged in this particular patient. This again the same procedure. So once you start the dissection in between the transabdominis muscle and the fascia. So once you've done this, then you're entering into this field, and this mobilization can be done very, very easily. The plane is very easily approached and can be done up to very extensively. This same thing done robotically. You can see the nerves in the vessels. So what are we dissecting out? What are we mobilizing? Now the mobilization of the face transversalis and the transabdominis. That means you can mobilize the transabdominis over the face transversalis. And up to what extent? From the edge of the defect, you can go right up to the diaphragm superiorly. You can go into the pubic area inferiorly, and laterally you can go up to the axillary line, or even posteriorly right up to the spine. So that is an extensive amount of mobilization that you can do, and you can fit all kinds of meshes to the particular area. And because of this extensive mobilization, all defects up to 20 centimeters can be made to be closed into the in the midline, and that is what the TAR is all about. This is the open bottoms up approach, And this is when you open the defect, and the defect, the peritoneum is there, and you approach the posterior sheath from posteriorly. Once you will posteriorly, you have the sheath in front of you, then you mobilize it laterally up to the side where you see the nerves, and then you cut it from bottom up or top down, and then you have this sheath along with the transabdominal fascia, which can then be made to close medially. Now, the same procedure can be done as a hybrid procedure, which is now also known as mini or less open sublate operation, or the Mills operation. Now, here basically you're using a light arm laparoscopic instrument using the endotorch. So you make an incision over the hernia sac. And don't make a full incision, a very small incision over the hernia sac, and through this you pass this laparoscopic instruments with something like resembling the Sills port, and this you can pass 2 or 3 instruments to this along with the laparoscopic endotorch, and you can do a complete mobilization like you were doing in an open procedure. Or you were doing in a full laparoscopic procedure. So here, this is slightly better because it is a combination of both the open and the laparoscopic procedure. So you're basically mobilizing again the same thing, the face transalis over the transabdominal muscle, as can be seen in this figure. So what is the status of CST as of today? If you look at the CST status, you've got grade B recommendation, which is quite a good recommendation, and grade C recommendation. So what are these recommendations all about? Number one, always add a mesh to any kind of CST or there will be high recurrence rate. So in most TAR cases, no mesh fixation necessary. Number two, large midline defects up to 20 centimeters width can be easily closed. Number three, always prefer a closure with a CST without a mesh where you have an infection. And number four, the TAR avoids large skin flaps with damage to perforator vessels, and in that, as a result of which, there is a reduction in the risk of skin necrosis, SSOs, and SSIs. So what are the outcomes? If you look at the endoscopic approach, the outcome is fairly equally divided between the anterior perforator sparing CST or a posterior CST with TAR procedure. But posterior CST TAR procedure is probably better because here you got a wide area where a mesh can be easily inserted. If you look at the open approach, again, the posterior CST with the TAR procedure is probably better because you've got a large area where mesh can be inserted, and that ultimately leads to a decreased amount of recurrence. The robot can be used for posterior CST with TAR, and that's the latest entrant into the armamentarium of a surgeon who is dealing with a ventral hernia. Remember, biological meshes cannot be recommended for CST. There's just a short video where showing a lateral TAP, and that also for epigastric hernia. There's a short video of 1 minute. The boards are same as for triform in the anterior lateral fixation like the under the muscle basically this mobilization is given as such, and the mesh when reduced can easily be able to reach the area where you have the defect, and you can completely collapse the perforator especially any infected but then it's very good. You can use a polypropylene mesh. Thank you. That's about all that I want to tell you about the repair of the ventral hernias. Thank you.